thank you for choosing to be here tonight. This is the Better Access, Better Care information session, and it's the 7th session in the series. I'm Carol Gabbana, and I'm the moderator for this evening. And what the evening will look like is a series of presentations. There will be Minister Doug Curry, the Minister of Health and Wellness, Dr. Richard Wedge, the Interim CEO of Health PEI, Matt Crosman, the General Manager of Island EMS, and Donna Murnahan, the Board Chair of Health PEI. And following the presentations, there will be opportunity for questions. So we'll be going from now until 9 o'clock this evening. I'd also like to let you know that there is simultaneous translation this evening. So if anyone is more comfortable listening to the presentations this evening in French, then I invite you to go and get a headset right at the back. Yeah, so without further ado, I am going to ask you to welcome Minister Doug Curry.
Well, thank you very much, and certainly want to acknowledge the crowd tonight. Thank you for coming tonight. It's a beautiful evening. And I see Mayor Basil Stewart here tonight, and I'm a little surprised that he's not in Truro. But anyways, I thought I saw him come in cheering his caps on. So I'll just want to acknowledge there's a number of MLAs. I won't go through them individually here this evening. Obviously, a lot of staff from Health PEI. Obviously, we have members from the PCH Foundation here this evening. We have some different community members from across the province that have been a part of this journey across the province over the last number of weeks. So, first of all, I want to thank you for coming tonight, and really tonight is an opportunity to obviously answer questions, but to also share information about the direction that we're moving in respect to healthcare. And really an opportunity to field questions, but really we want to make sure that during the first part of the presentation we get a lot of good information out to really clearly demonstrate what our commitment is, what our commitment has been, and what our continued commitment is to the Prince County Hospital. The PCH is a facility obviously here in Summerside, but it's also a healthcare facility that provides a high volume of services to the region, particularly in the western region. But it's also a facility and hospital that does provide other services east of Central Queens. So as the minister, obviously I've been involved in this file now for a number of years. Very challenging portfolio, large budget. Currently, the budget today in our province for healthcare is approximately $570 million. In the last 5 years, we've seen an increase in spending of an additional $200 million, and with a real strong focus not only on our acute care delivery, but also particularly in home-based care, primary health care, and really trying to continue to evolve healthcare to meet the needs of the changing trends in our province. And the two trends are very simple. The two trends are we've got a population that is getting older, and we've got higher than average volumes of chronic disease across the province, which obviously continues to put pressure on any healthcare system. And our challenges here in Prince Edward Island are no different than any other jurisdiction in the country. The advantage that we do have here in Prince Edward Island, we're smaller. We're a population of 146,000. We've got 2 acute referral hospitals. We've got 5 community hospitals. We have a provincial mental acute facility, and we also have a provincial addiction detox facility. So as the minister, I see a province with assets, and the real focus of the journey forward is making sure that we utilize and use the resources and the assets we have in our system to our full potential. Currently today in the province of Prince Edward Island, out of the approximately 475 beds that we have that provide health care across the province, and that's not long-term care beds, we have approximately 200 medical beds which are designed to serve and provide access for our most sick islanders. Currently today, we would have approximately 80 of those beds that are being tied up by non-acute patients. So the focus moving forward is to look at ways that we can provide better access whether it be to family physicians, whether it be to emergency services via emergency rooms, whether it be through ground ambulance services. We've introduced a number of new initiatives that will continue to take the pressure off. Currently today, we're seeing an increase in out-of-province transfers. So really the second largest facility in the province is actually out of the province. It's a $50 million budget which provides healthcare services to all islanders, which we provide services, whether it be the IWK, whether it be the QE2, whether it be in Fredericton, St. John, Moncton, Toronto, wherever the service can be acquired to provide healthcare for islanders. So with that being said, the challenge is how do we continue to evolve our system to respond to the demands and meet the needs of islanders, whether it's in Stanley Bridge or Borden or Tignish or Surrey or Charlottetown. Currently today, there would be approximately 1,000 islanders getting healthcare services at the Prince County Hospital and the QEH that would be coming from all areas of the province. So these two facilities, the larger facilities particularly, are providing health care not only to their communities, but to their region and to islanders from tip to tip. So the focus here tonight is to answer questions, to give information. Certainly as the Minister of Health, I've been very engaged, had numerous discussions with Health PEI and particularly the Foundation in respect to the vision and the plan for the Prince County Hospital. And I want to reassure everyone here tonight that our government is soundly committed to services that are in Prince County Hospital. And currently right now we're also looking at a number of initiatives, one being some clinical initiatives, looking at repatriating services that are currently off island and bringing those back to the Prince County Hospital. That's preliminary. We're also working with a medical school right now to look at bringing in and enhancing the medical education training program, which would bring medical students to the community of Summerside and to be do a number of the rotations here at the Prince County Hospital. So there is initiatives that are in place that we're working on, and I see the future of the Prince County Hospital to continue to be a viable, key integrated part of our provincial healthcare system moving forward. So with that being said, I'll pass the presentation over to Dr. Wedge, the interim CEO for Health PEI, and we'll go from there. Thank you very much.
So thank you very much. I'm going to go through a number of slides that are related to the government announcement from about 6 weeks ago, as well as some more slides that are specific mainly to the Summerside area. So as you can see on the slide, there are a number of facilities within Health PEI, both acute care hospitals, what we're looking at to be extended care hospitals, as well as manors, primary care clinics, public health clinics that are being operated across PEI now. And all those facilities are going to continue to be used to their fullest capacity, although the beds are going to be reprofiled a bit following the announcement. Essentially what we want people to do is to be admitted to an acute care bed when they need to be. And when that hospital stay becomes prolonged for some reason, whether it be a post-operative infection or a stroke where they need more rehab, that they would move to a facility that's better able to look after that care. And then, of course, the vast majority of people then going home, some going home with home care, but some going directly home, and then some patients that will go to a long-term care facility. Wanted to point out to members of the audience what extended care is. And extended care, there's about 9 different types of extended care that we offer here in Prince Edward Island, but the main ones being restorative care that occur after somebody has a stroke and they have various issues with their activities of daily living, such as being able to feed themselves, climb stairs, the mental capacity to do their mathematics for getting groceries and that kind of thing. So they do have a specialized area there. There's convalescent care for some people that have prolonged surgical recoveries, respite care for families who are looking after people with chronic illnesses in their home and they need a bit of a break themselves. And then, of course, things like palliative care, end-of-life care that can't be delivered either in a home or the patient prefers to to receive palliative care in a hospital setting. So the thing to point out, though, that extended care is not long-term care. People that are in extended care actually need 24-hour-a-day nursing care with medical observation. So it's not the same as being in a manor where the patient actually lives in the manor for the rest of their life. So it's a whole different thing. So as part of the government announcement on refocusing the community hospitals, Stewart Memorial Hospital is going to be converted into a 23-bed long-term care facility. It currently has 15 long-term care beds now and 4 acute care beds, as well as 4 additional alternate level of care beds. Community Hospital Larry and the Surrey Hospital are both going to become extended care facilities, Surrey being a 17-bed facility and O'Leary being a 13-bed facility. Both Western Hospital and KCMH are going to be our main acute care centers, and they're going to be the acute care centers because that's where the emergency rooms are located, and you have to have certain services there to be able to support the emergency room because that's where people are going to go for emergency care, obviously. Prince County Hospital and Queen Elizabeth Hospital are going to be remaining as our specialized referral centers, the same as they do now, and they will continue in that role. This slide is just to explain to people what the Collaborative Emergency Center is that will be established in Western Hospital. And basically what will happen there is the physician and nurses will be on site from 8 in the morning till 8 p.m. at night for emergency care. The ambulance will still be coming into the Alberton Hospital from 8 to 8. But after 8 o'clock, the physicians are going to go home, and a nurse, and either a nurse or a nurse paramedic are going to be looking after any patients that come in after that. So that model hasn't been quite determined yet, but essentially they will both assess the patient and they will make some determinations whether they're going to treat them and send them home, treat them and bring them back in the morning to see the physician, or send them on to Prince County Hospital for emergency care if they actually need care that night. So this model has been active in Nova Scotia for the last 2 years and is now being set up in the Saskatchewan province as well. And then earlier today, I actually did an interview with the Whitehorse General Hospital where they're looking at this model for some of their hospitals in the north. One of the other initiatives that were announced is a province-wide 811 telehealth system that's going to be operating 365 days of the year, that people will have health concerns will have access to a nurse professional that's at the other end of a phone and will provide advice to the patient as to something they could do for themselves to treat whatever health concern they have, or they may refer them to their family doctor, they may refer them to diabetic clinics, they may refer them to emergency rooms depending on what sort of problem the person has. The other advantage to this is it's available in multiple languages so that people will be able to be comfortable whether it's in Chinese or French and other languages that are now in Prince Edward Island. So more specifically to the Prince County Hospital, just some quick stats. The average daily bed count at Prince County Hospital is about 89 patients. There's about 4,100 inpatients admitted and discharged each year. There are around 27,000 emergency room visits that occur. This number is actually down over the last 2 or 3 years because of a number of primary care initiatives that we've had in the East Prince area. So the numbers tend to vary a bit, but it's stabilized at roughly 27,000 over the past couple of years. There are about 2,600 surgeries done. These are both inpatient surgeries as well as ambulatory surgeries or day case surgeries at Prince County Hospital. The vast majority, of course, being day surgeries that people come in and go home on the same day. The C-section rate is about 25%. It's slightly lower than the provincial average. There are a number of ambulatory procedures that are done at Prince County Hospital as well, so endoscopy and people that are having a gastroscope or a scope that looks down into their esophagus or their stomach, as well as a colonoscope for bowel disease. There's about 2,700 of those. There's a number of physiotherapy clinics. We stabilized at about 461 births, which is well down from the 1990s. I see Dr. King was in the audience there. He probably delivered 461 of his own in some years. The Prince County Hospital has about a 97% satisfaction rate on the patient surveys that are done. And the operating room operates at about 86% capacity. So there are some days when there's some operating room time available. But 86% is considered quite good. Most hospitals will operate in around the 80 to 85%. So that's actually quite good. So again, Prince County Hospital is our second largest acute care referral facility. There's a number of services that are there. Of course, the emergency room, general medicine, both internal medicine and pediatrics, surgical day surgery and inpatient surgery. We have an intensive care unit. We have a step-down unit called intermediate care. We have a progressive care unit as well. And we have a number of inpatient units, about 7 of them. The medical floor that people might be familiar with, a surgical floor, a maternity and child floor, a special care nursery for some of our sicker children, newborns. Of course, our palliative care beds as well, a restorative care unit that was set up with the new Prince County Hospital, and an inpatient mental health unit as well. These are some of the ambulatory services that are done in the new ambulatory care wing that was opened in 2004 as well. Endoscopy, minor surgery, some cancer treatment, various nursing procedures. The secondary stroke prevention clinic for the province is actually located at the ambulatory care unit as well. The rehab services, both physiotherapy and occupational therapy for patients with strokes and various limb disabilities. Nutrition counseling, some testing for asthma and heart disease, exercise stress testing, that kind of thing. Our asthma and COPD or lung disease education unit is in there. Obviously, the specimen collections as well, that people being sent from the Summerside Medical Center or Harborside. A health resource center for the community to go in to learn about their chronic disease and how to self-manage, as well as outpatient mental health and addiction services that are done through community mental health. Another addition that was done in the last year or so is the new hemodialysis unit that was added on to the Prince County Hospital. And just for people's knowledge, there are about 467 full-time staff at Prince County Hospital, including about 420 registered volunteers. Just for interest for the audience as well, we have about 54 medical staff at the Prince County Hospital, including 8 full-time emergency physicians that obviously spend all their time there in emergency, and that's a big change over the last 15 years when the family doctors used to take turns on 12 or 14-hour shifts in emergency. But these physicians are dedicated to the emergency department. We have 4 psychiatrists, which is up from 3 that we've had traditionally for the last 10 years or so, but we've moved to 4 over the last 2 years. We have a new position in internal medicine. We traditionally had 4 and now 5, although the 5th position has not yet been filled. We have 3 obstetricians, 3 anesthesia to support the operating room, 3 general surgeons, including our new one that just came a few months ago. We have 2 ear, nose, and throat surgeons, 3 pediatricians, and 22 full-time family physicians that work at Prince County Hospital. So this graphic is showing where people are being hospitalized. So the one that's on the far right with the dark green is obviously most patients that are in the Prince County Hospital come from the East Prince area, but the people that live in East Prince, the majority are in Prince County Hospital. The other 15% that's in kind of the bluish purplish area are East Prince residents that essentially go to the Queen Elizabeth Hospital for their acute care. Not very many people, in fact almost none, are admitted to West Prince from the East Prince area or to the Kings County Hospital. Then if you look at the one that's on the far right, people that live in the West Prince area, the vast majority are admitted to the Prince County Hospital, the Western Hospital, and the Queen Elizabeth Hospital. So it's about 86% of West Prince patients are admitted to those 3 hospitals. This is a stat around the inpatients awaiting beds. So what happens there is people are admitted through the emergency department, and there is actually no bed at Prince County Hospital for them. So they receive some or all of their care while still in the emergency room. So if you look on the far right at the Queen Elizabeth Hospital, there's about 12 patients every day who are receiving care in the Queen Elizabeth Hospital emergency room, and about 2 on average every day at Prince County Hospital are receiving care in the emergency room. And this could be for 2 or 3 days at a time, although we try and get them out at least after 24 hours. So if we look at our current bed utilization, these are just for the medical beds, obviously, for the various hospitals. The one on the far right is the Queen Elizabeth Hospital. There's about 30 patients on any given day that are not receiving acute care. At Prince County Hospital, it's about 11 or 12 patients every day. Should have glasses. I guess it's actually 17. It looks like a 12. 17 patients in any given day at the Prince County Hospital. And then if you combine the hospitals in the east and the west, there are a number of patients who are also receiving alternate levels of care. This is the statistics around the emergency room waiting time, because there's been a number of questions around that. This is month to month over time. The blue lines are for patients who require emergency care. These are people with level 1, 2s, and 3 care that often will come in by ambulance, or the level 3s can be brought in by themselves. But on average, there's about an hour and a half wait at the Prince County Hospital. This is from 8 o'clock in the morning until midnight, so we've excluded the data for after midnight. But on average, the emergencies wait about an hour and a half, and on average, the people who have what we call family medicine type situations who go to the hospital, our level 4s and 5, wait on average 2 to 2.5 hours at Prince County Hospital. So this is a slide around the occupancy rates for Prince County Hospital. It's currently about 85% of the beds are occupied in any given day. Mainly the beds that are not occupied are in pediatrics, obstetrics, and in general surgery. And that's mainly because we do try and keep some of those beds open for children or for women that are in labor, as well as some of the surgeries that come in through the emergency department. So we try not to put our medical patients on those floors when we can avoid it. So who's using the Prince County Hospital? If you look on the far right, obviously it's people from the East Prince area. The traditional catchment area goes from about the Mount Pleasant area down to Prince County Hospital, and then to the east, usually around the New London, Stanley Bridge area. If you draw a line across to Crapo, Victoria by the Sea, is the traditional catchment area. But as you can see, there's a number from West Prince. About 6% of our patients actually come from the Queens County area. These are the inpatient admissions using our inpatient beds. And about 2% of our patients are actually patients who come from off-island, who may be tourists here, or they're covered by OHIP, those sort of things. And a very few, less than 1%, come from the Kings County area. So just a bit of information around the primary care networks. PEI has been divided into 5 geographic areas in terms of primary care, and they're roughly equivalent in East Prince, and Queens County has been divided into 2. So those are roughly equivalent geographical areas. And then Kings County and West Prince have they have smaller areas, but they have smaller staff, but it's designed to be equivalent. So the goal is there to try and enhance primary care services and try and equalize services across the province, to try to integrate services between family physicians, nurses, dietitians, social workers, pharmacists, physiotherapy, that kind of thing, and then try and improve the services from that point of view. Part of the goal around having the primary care networks is to try, if people can see their family doctors, they spend less time going to the emergency department. If they spend less time in the emergency department, they're less likely to be admitted. When they are admitted, if they have better primary care, their length of stay is going to be shorter. So in Summerside, the East Prince Primary Care Network, essentially it has 3 main clinics. the Summerside Medical Center that's been here for a number of years, the Harborside Clinic that started in about 2001, 2002, the Kensington Family Medical Center that's been in place probably since the early 80s or so. It's been quite a while, and we do have a small satellite clinic being operated in Evangeline in the Wellington area. So some of the services that they've been operating out of these clinics are to try and improve people living with chronic lung disease, like our COPD project that's been run out of the Harborside Centre. And these are people that have chronic lung disease who are having intensive treatment and intensive follow-up so that they can help manage their own disease to try and decrease the number of times they've gone to emergency rooms and then decrease the number of times that they've gone into the hospital. That project, some of you probably saw on the news over the last few years, but that has decreased the number of visits to the Harborside Clinic with COPD plus a number of other initiatives have decreased the number of visits to the Prince County Hospital Emerge by about 1,000 visits a year. Some of the other initiatives that they have going at Harborside are the Well Women clinics for breast and pap tests. They have an obesity management clinic that's being run out of both Summerside and Kensington. We're in the planning stages for a number of other projects at the Summerside Medical Center. They also have a rapid access clinic for the patients of the Harborside where they can have prescription refills done to try and improve the access to family medicine. They also have a nurse practitioner at Harborside as well, and I'm not sure if she's here tonight, but that has been a great success for the people of the Summerside area as well. So those are some of the improvements that we're looking at delivering through better access, better care for Islanders. So I'm going to turn it over to Matt, I think.
Thank you, Dr. Wedge and Minister Curry and all of you here tonight for giving me the opportunity to address you. I know I recognize a lot of the faces in attendance tonight, so I'll just ask those that have seen the presentation before to just bear with me, but I do think some of the information is important. I'm going to go over Island EMS, how it began, where we're going in the future, and at the very end of tonight's session, you'll have an opportunity to ask any questions you may have. I'll also offer that if you don't have an opportunity tonight or you don't feel comfortable in a public forum to ask a question, you can contact us at any time, either through our website or through our general inquiry number. And I do see our Western manager, Claude Gavin, in attendance tonight. Island EMS began operating a province-wide ground ambulance service in 2006. We took over from 5 private ambulance operators who did a great job and became one provincial system. We have bases in Alberton, O'Leary, Summerside, Charlottetown, Montague, and Surrey, as well as different posting sites throughout the province. Some of the benefits which we've been able to implement within a province-wide system are that we're able to utilize all of our ambulances across the entire island. And what I mean by that, previously when the 5 previous operators were in operations, they were within their geographic area, and when they left that area, they weren't able to respond to calls outside of that area. Now with the provincial system, if the Summerside area happens to get busy, we're able to pull other resources, for instance, from Charlottetown into this area and cover our different areas so that we are able to provide emergency care. Island EMS has approximately 140 paramedics, and with the new initiatives, which I'm going to talk about tonight, we're looking to hire an additional 7 full-time paramedics. We have different ranges of skill level within our paramedicine. We have primary care paramedics, intermediate care paramedics, and advanced care paramedics. Island EMS has worked very hard over the last couple of years to ensure that all of our ambulances are staffed with advanced life support paramedics. There's a booth set up at the back of the room tonight with some paramedics available for questioning and some information which you can take home that really highlights the skill level of the paramedics and what types of interventions and medications and skills that they can bring to the communities. We've really worked hard within the last 2 years to improve our clinical quality of care and really expand our scope of practice for our paramedics. We audit 100% of all of our medical calls. We always look for ways to improve our patient care. We look at a lot of evidence-based medicine and really try and make sure we maximize our care levels to our patients. We also have an ambulance outside after tonight's session with 2 advanced care paramedics. If you'd like to ask them any questions or have a tour of the ambulance, by all means you can do so. We have 19 units currently within the system without any of the additions which we're going to talk about tonight. They range from a multi-patient transfer unit, which some of you may have seen before, that has a capability to take multiple patients, to our single-type Mercedes ambulances, which have a single powered cot, to our modular style ambulances. Some of the enhancements which we've been able to bring to Prince Edward Island over the last couple of years is a centralized dispatch communication center. Medicom Atlantic, who provides our emergency medical services dispatch center, also has a long-term contract to provide 911 throughout Prince Edward Island. The benefit that this gives us is the information comes into one single center and we're able to access that information very quickly. And many times while the communications officer is still on the line with the caller, we're able to get our ambulances moving that much quicker to the scene. We may not always have the information until the call is transferred over, but we are able to get our crews moving very quickly. We've standardized all of our fleet, equipment, skill levels across the island to meet all the national competencies across Canada, and we're really pushing paramedicine into the next future to try and deliver a high-quality ambulance service. We've really enhanced the scope, as I talked about before, within our different levels, not just advanced care, but also our primary care. Our paramedics are now able to give a maximum skill level of treatment to our patients. An example of this is previously we would administer a certain medication where now our paramedics are trained on certain classes, which really opens up the amount of different types of medications they're able to administer. When the call comes into 911, our treatment starts right away. We're able to determine the nature of the illness of that patient's need. We're able to really start to alert the different facilities, the nursing staff, the paramedics, also the physicians, and also our medical first responders. When our paramedics arrive on scene, we're able to administer medications very quickly. We're able to consult with physicians through online medical control. Something new that we're just implementing as we speak is a 12-lead ECG transmission. Our paramedics will be able to arrive to a scene, hook a patient up to a cardiac monitor, and send a 12-lead ECG to the physician either at Prince County Hospital or Queen Elizabeth. That physician is going to be able to interpret the 12-lead ECG transmission and prepare for that patient once they arrive to the hospital. Some of the new enhancements which we're going to talk about tonight, one of them is our rapid response units. We're going to have an Eastern Rapid Response Unit and a Western Rapid Response Unit, primarily located in the east in the Montague, Surrey area, and in the west, Alberton, O'Leary. These enhancements into the system are not only going to affect those areas, but also our Summerside and Charlottetown areas. They are additions into the service. They're staffed with a highly trained advanced care paramedic with capability to contact online medical control. When the paramedic responds to that scene, they're going to be able to start treatment immediately. An ambulance is going to be dispatched as well to the location. But the major difference with this new initiative is once the paramedic has started his treatment and the ambulance arrives with 2 more paramedics, they're able to transfer care to that oncoming ambulance, and now they're able to go back into service. So before, when we would have to transport the patient to the facility, we would remain out of service until we were clear from that call. Now, once we transfer care over, we're going to be back in service and we're going to be ready to respond to the next emergency. A lot of the time, that's what impacts our response times, are those multiple calls, one right after another, and we really believe this is going to help improve our response times across the island. Our next initiative is the ambulance transfer unit, which looks very similar to this vehicle on the screen. The ambulance transfer unit will be equipped with a wheelchair lift and a powered stretcher lift as well. It will really help take the load off the system, especially here at the Prince County Hospital and the Queen Elizabeth Hospital. Right now, we're doing a lot of interfacility transfers. It's about a third of our call volume on any given day. We're doing around 16 Monday to Friday, and this enhancement into the system is really going to allow our emergency ambulances to respond to emergencies. We're going to be able to take this ambulance transfer unit, schedule it for appointments throughout the day, and we're going to be able to meet those appointments, which is not only going to improve the patient's ability to make their appointments, it's going to make the physicians and the nursing staff and all of the facilities much more easily able to adapt. Sometimes now when we transport with an ambulance, we may get hit with an emergency call. We may be delayed taking that patient to that facility, and it really not only impacts the patient but also the facility as well. So we're very anxious to get this vehicle in operation. We really think it's going to help improve our overall response times, but also the patient's ability to make their appointments. So we're very excited about this initiative. Thank you very much for your time, and I look forward to talking to you after.
How's everybody doing? It's a lot of information coming at you. My name's Donna Murnahan, and I'm the board chair. And so tonight I thought I'd give you a few slides just about how we're moving forward on a strategic plan that would go from 2012 to 2016. And a strategic planning document has been in place for several years, but it was finishing up the old one. And then over the past year, we have been, as a board, as an executive leadership team, and as stakeholders and staff and people in the community, engaging in what do we do now and how do we go forward. And that's always the most important part. And really what we want as a board and as a system is to have an island system that's the best for you for the future. So I think I said in Tyne Valley, for example, the most important part for us is what's the right service for one integrated island system, and how do we ensure the best service for all of the population, from our newborns that are in the province now right through to our seniors. So it's for all population. And the idea behind it is that we are very proud of the system that is in PEI already. And the interesting part is that if we're going to continue to be proud of our island health system, we need to ensure that the resources and the services that we provide are the best that we can provide for the future. So our children and our grandchildren are counting on us to make decisions today that will benefit them for the future. So we have to work together on that. So the three primary goals that we have set for the future and continue to be from the past as well. Number one is quality. As some of you know, that as a system, we actually are accredited. And an Accreditation Canada comes in, and one of the things that is critical to getting a full accreditation as a province is that we meet the dimensions of quality. So what is the best practices, whether it is in our hospitals, in our long-term care facilities, in our home care, in our public health departments, in our mental health programs. So it's the entire system that we have to pay attention to. And the most important part is safety. Each of you are counting on us ensuring that the care that you are provided is the best care based on best practice standards. And so that is the dimension of quality that we're really trying to reach out for. The second is access. We've heard so much about access over the last 7 meetings particularly, and tonight's meeting is really a case in point. What is the right access, and how do we provide the right access by the right provider in the right setting? So this has to be across all the dimensions of our system. Our hospital is one very critical part of that system. Primary care networks is another component of that a lot of people are saying, what's a primary care network? And some of you have experienced that here in the Summerside area and know what those are like, but we need to get more information about it. What's available in long-term care? So what's available in home care? So home care in this province is a critical part of our system. We would prefer, people tell us they prefer, to actually be able to have home care services whenever possible, as opposed to staying in an acute care hospital where they don't feel like they belong, or going to long-term care facilities before they really are ready or want to do that. So the access issue is really a critical point for us. So who's the right provider to provide the service to you, and what is sustainable? And the final goal is looking at efficiencies. And efficiency isn't about cuts. Efficiency is about getting the best service based on what we have available in the system, and what are the processes or what are the ways that we can ensure that efficiency meets the needs of the population. So how do we get the right service at the right time in the right place? Those are critical. Now, I'm going to draw out a little bit about what is the access priorities that we talk about. And one of the things that has been in our data, for example, from a group called CIHI, that collect data across Canada and give us information about how are we doing in PEI compared to other places in Canada. And one of the things we're trying to do is try to ensure we meet the wait times within a reasonable level. And if we're not meeting them within a reasonable level, what kind of changes can we do to make those happen? So for example, a lot of people here that everybody says general practitioner. Does every person on PEI have a primary physician at this time? No. Is there efforts being put in place to try to ensure that primary care physicians are available to the population? Definitely. Who are the other care providers, though, sometimes that you could access, who could meet your needs? So what are we doing in terms of, as a province? We've announced this week about the nurse practitioners and getting information about what is a nurse practitioner, what kind of scope of practice do they have, and how can you access them? What does a registered nurse provide for you? What kind of level of service and where are they positioned? What's a dietitian provide for you? Because when I think about it, that's really important as well. Another wait times is long-term care facilities. There has been an enormous move to look at long-term care beds and changes to the system so that the long-term care beds that are available are really up to good standards. And that's really critical. So where are they positioned and where are they placed? That is part of the process. Mental health and addiction services consistently at every meeting I've been at. I've had either side conversations or people at the microphone very, very concerned about mental health and addictions being an area of great need of this province. Everybody in this audience can say, I have either a family member or a friend that is affected by mental health and addictions. But we need to also look at why are they being affected by mental health and addiction issues. Some of it is genetics, but some of it is about our environment, our communities. So how are we reaching together to actually prevent mental health and addiction issues as well as chronic diseases? We need to target these things early. And so in terms of accessing priorities, it's not about hospital services to treat the mental health and addictions, which is one part of the continuum, but what are we doing to help get the information out to our children, to our young adults, to our adults about what we can do and what are the services and resources to teach, to guide, to prevent, and then treat if we have to. We got to do something, I call it back the truck up, folks, because we need to prevent some of these things, and we're not doing a very good job on that. Elective surgeries is another access priority that we're really concerned about. The wait times have been not where we want them to be. So the announcements, for example, about the new surgery units and the surgeons to the team, those are how we deal with it. But we also, as the minister was talking today, we have to make sure if you have an elective surgery, I don't know if it's happened to you, it's happened to lots of people I know, your elective surgery is booked and it all of a sudden is canceled because you don't have a bed. That's not good enough. So what are we doing to make sure that doesn't happen? Emergency services, that's a big issue. I've heard all for the last 3 weeks. Emergency services, getting the right people who are true emergency services into ERs and using our primary care centers, using our evening clinics, day clinics, and those things to look at services that you need. And the final access priority that we're looking for the future is vulnerable populations. Vulnerable populations such as children with needs, special needs, mental health and addictions, people who have serious chronic diseases. We actually need to make sure that we're providing services so that we can keep people out of hospitals and prevent them requiring long-term services in institutionalized care. So these are just a quick snapshot of what the strategic plan is but we're aiming to go forward on, and you'll hear more from you. Thank you.
Thank you, Donna and Matt and Dr. Wedge and Minister Curry. And now it's time to invite questions from all of you. And I'd like to ask you, when you have a question, to come to the microphone there. Or if you can't come to the microphone, I have a handheld one, and I'd be glad to go to you. You just need to wave to me. And if you want to ask your question in French, then when you come to the microphone, just let us know that so that the folks at the front here can put their headsets on and they will be able to understand your question and respond appropriately. When you come to the mic with your question, it would be great if you would say your name so we know who you are. And as I look at the audience tonight, and I've been at almost all of the meetings, I see a lot of familiar faces. And I know that people have lots of questions. And I do want to ensure that the people from this area, from the Summerside area, are able to ask their questions first. So we want to ensure that people have an opportunity to ask their questions and that the people who are from this area are able to come up to the microphone first. So if we'd be able to do that, that would be great. So I invite your questions now. Whoever would like to come to the microphone, it's yours.
Good evening again. I guess I might have been a little out of order in O'Leary, but I waited to the end in O'Leary. So, but a panel, I believe I know you all, but to the audience, I know a fair number of the audience here, but to those that I don't, my name is Gordon Coffin, and I've been in the executive of the Prince County Hospital Foundation for over half a dozen years, and I'm presently in the role of president. So. It's interesting to hear these the presentation tonight. I'd like to thank Minister Curry. I think it was a commitment to the long term of the hospital. I was hoping it was worded a little bit stronger, but anyway, I think there was a commitment from him. So thank you, Minister Curry. I have spoke to Minister Curry before, Minister Bertram, Mr. Curry, former chair of the Health PEI, and most recently Donna is the chair of Health PEI, as to try and give us a goal or a challenge out there as the Hospital Foundation. We have some wonderful donors. We go to the community, we get a very warm response. I'm looking up at the gentleman that delivered your water to you there, and that was Minister Sheraton over there. And before he was in government, he was actually a volunteer canvasser for the Prince County Hospital Foundation. And he did an excellent job, and can't do that now in government, but he was certainly there and an excellent campaigner. So with that, We have those donors that will make a donation for Lights for Life, but we also have donors that will step up, that when challenged will write those checks for $50,000. We had a person this year that, or last year now, 2012, made a commitment of $250,000. Okay, and it goes to, I want to ensure the long-term viability of Prince County Hospital. So my ask, again, and I've asked it before, is to come up with a plan that says that in a couple of years' time, we're going to bring this back to PEI. You say there's $50 million that goes out of the province, and maybe some of it can be done here. We can look at it. The Hospital Foundation would be glad to partner with Health PEI in the province and turn around and say, yeah, to ensure the long-term viability of the Prince County Hospital, that we can do this, be it whatever it is, okay? It might save the government money. We don't know. We look at it. There's things that have been repatriated back to the province over the years. You know, I can remember when I lost my mother-in-law to cancer, the treatment was all in Halifax. It's now here. Can we do something like that here? So that's as much a challenge, I guess. That's the first statement. So if as far as that goes, I don't know if you want to just, I'll leave that challenge out there, or you want to comment to it. I have another little question, but so.
Well, thank you very much, and certainly it is a great question, and certainly I want to acknowledge the work by the Foundation, by yourself, and past chairs. I mean, you've done an outstanding job. I've had the opportunity as the Health Minister now to be in a number of conversations, and certainly I respect the work you do, and certainly value your role into the future in respect to the function and purpose of the facility here. As I alluded to in my opening comments, currently right now, I believe there's a meeting scheduled in the near future to sort of sit down and have a more candid, frank conversation about that. But there's a number of initiatives right now that we're currently working on. I can't get into too much detail. There's one where we're looking at the role. We're working with a medical school here in the region, where we're looking at bringing in third and fourth year med students to actually live here in the community, to implement part of their training here. So very positive initiative. We're also looking at two clinical initiatives that would provide new services, one in particular, and the second would be a repatriation of a service that's currently not being provided here in the province. So not only are we doing that, but we're also in conversations with other provinces. The premiers met on Monday, and there's certainly lots of conversation going on about regional collaboration, about specialty sites in respect to providing services. So certainly I think there's tremendous opportunity. Obviously, from an operation perspective, Health PEI has to continue to lead. From a policy perspective, we'll continue to lead, but from a community perspective, certainly we're very interested in continuing to build and to make sure we get good clarity and communication on the division and direction. And as I said, we're extremely committed to the facility, and if you look at the statistics and the numbers in respect to what the Prince County Hospital is doing here in the province of Prince Island, it's a key player in the delivery of services here in the province of Prince Island, and our intention is to continue to move that forward. Thank you.
Thank you, Mr. Minister. Another, you brought up, I've heard you speak a couple of times about the first available bed, and when I think through it, I think there's a few little flaws in it. I must commend you for your gumption to stand up. You said you stood up to your some of your local, your other MLAs and cabinet and say, no, this is the way it's going to be. It takes a lot of gumption to do that. But when I think through the process, I said maybe there could be some, I think there could be some flaws in it. One is if Mr. and Mrs. Senior, who say live in the town of Kensington, and they come to the Prince County Hospital for critical surgery, and they find out that the spouse is going to be in Alberton or Surrey or whatever, what you said would happen. One, that partner, if they can drive, will not be traveling near as much. So when you don't have that family network there, be it friends, the spouse, if they can, you know, if they're fortunate enough to be elderly and still have a spouse, I think their recovery time is going to be slower. So it's going to be a few more days in bed, okay, which is a cost. And there's going to be probably another healthcare worker doing some of the work that is not done or the family network or the friend network is not there to support, okay? I know there's got to be critical decisions made, but that's just something to throw out on the table as well. So.
Thank you, Gordon. So I'll speak to that a bit. You're exactly right. People from Kensington coming into Prince County Hospital for surgery and then being transferred to O'Leary is going to be a hardship for that family. But I also look at it for the people of Tignish, who, if they need surgery done, they have to come to Prince County Hospital as well. And that does separate spouses who may be elderly and can't drive as well, or rely on families to bring them into Prince County every day for their surgery. So that does occur in rural PEI now when they come into Summerside and Charlottetown for various services that are there. So the number of times that has to happen hopefully will be small for everybody that's involved. The other alternative, of course, is to expand the Prince County Hospital and then not utilize our facilities at all in Alberton and O'Leary. And I don't think anybody's interested in closing facilities.
Yeah, there's no win-win. I just wanted to say to the minister, make a point that we don't need to keep a person in the hospital a day longer if it can improve their care.
Yeah, I mean, obviously the discussion, obviously we have a policy in place. It's a repatriation policy. Obviously the issue is, if you saw in the statistics, in our two larger facilities that provide all the surgical services here in the province at the QEH, and the Prince County Hospital. Obviously, we have people in emergency rooms. Our wait times in emergency rooms in our two facilities are higher than the national average, and we know that the longer people are sitting and waiting in emergency rooms reduces the overall health outcomes with the longer they wait. Obviously, we don't want people sitting in stretchers, particularly people who are elderly, sitting in observation rooms. So for a number of months now, we have a repatriation policy in place, first available bed, where an individual who has received their acute care is at the back end of their post-op recovery. They'll get transported to a facility for the last few days. And I'll share a story. I got a call a week ago from a very upset individual from Charlottetown. Very credible family, very well-to-do, and I think they may have been a Liberal. I'm not sure, but I don't think they are now. But anyways, to make the long story, their grandmother went in for surgery, had great care and service, and went through the system, and was repatriated or transported to Surrey. They were upset. They refused. They didn't want it to happen. And I just basically said, I'm not getting involved. This is exactly where we're going as a system, because we have to free up that bed because there's people sitting in the emergency room waiting for a bed who's more sick. So anyways, phone call ended. 4 days later, phone call came. Same individual acknowledging the tremendous care he received in Surrey. The family was absolutely delighted. Their grandmother was pleased. She was released and she was home. So there is some good stories, and we do have assets in our system, and we got to continue to have more of those stories. And it's a change from the traditional way we've been doing it, but we're at a point right now where we have to use our facilities. And as I said to people, if we can drive people into Charlottetown and Summerside, we can drive out as well. So thanks.
I've often heard that argument that it's farther to go one way than the other. But anyway, the point I guess I was trying to drive home, and I understand we got to change and we got to clean up this backlog and stuff like that. But it is important to get the people as close to home as possible for that support network. For one, it doesn't drive up healthcare costs, and it helps families to be there and stuff. So just one. I know there's a whole bunch of other people probably want to ask good questions here, but one more. And I'd asked this one a couple of weeks ago when the foundation had a meeting with Health PEI. Minister Sheraton, I heard him speak different times and say the requirement to implement HST, and that we needed to be in an even playing field with our sister provinces, that the fact that we didn't have HST has left us with a disadvantage. So we now have it, same as New Brunswick and Nova Scotia. We have, as the Prince County Hospital Foundation, and there's other hospital foundations and the other hospitals around here, we raise money to buy equipment that medical staff say, here's what we need for the year. Our goal for this year is $1.3 million. I have not heard any decision as yet as to a rebate on HST. Okay? In Nova Scotia, in Nova Scotia. It's unfortunately he's not in the front panel here. Okay, okay. I would ask him Monday, but he was in Ottawa. So anyway, out of that 1.3 million, if we do not get a rebate, it's going to cost us 117,000. In Nova Scotia, they get 83% rebate, and in New Brunswick, they get 100% rebate. So, any decision yet, or any commitment yet, or so?
Well, it's that's the first time I've heard that question, but obviously when we meet with the foundation, obviously if other provinces have already implemented that policy, certainly we'll make that a priority. I mean, that's a large volume of money from a capital campaign. So I'm glad the Minister of Finance is in the audience and is hearing this discussion, because we'll probably be having that conversation tomorrow morning. So thank you.
Yeah. Thank you.
While I'm waiting for somebody else to come to the microphone, one of the things I had an opportunity to do has been to tour as a nurse educator. I've been in every institution across PEI, but one of the things we often don't talk about is the equipment and the services that are provided by volunteers through the foundations. And I can honestly say I hadn't been through all of Prince County Hospital for quite a while, but I did this year, and I was envious of the wonderful equipment that has been provided by the foundation. So the important role you play in terms of being able to deliver really critical care to all the public is important. And by working together across foundations, we're looking forward to seeing that more. So thank you.
Good evening, Minister Curry, Dr. Richard, colleagues. I'm not going to get into a long, drawn-out affair about how bad things are, because we know things are bad and we can all use improvement. But I have one question for you, and I don't know if you can answer or not. The problem with healthcare started by your grandparents back in the 90s, the previous Giz administration. You took control of the facilities to government. You're getting rid of people. You're not doing community boards. You're taking ownership. If you want things to work, I have 15 jackets in my closet, and I wore my co-op jacket tonight. Because to get things done, you have to cooperate. And there is no cooperation. The community boards are gone. Governments are good at a lot of things. They're good at building buildings. They're good at giving loans. They're good at financing. But they're not good. Since the beginning of time, people directed their education and they directed their healthcare. Healthcare started to erode in this province when we took it away from the communities and the people. If you run a business and you want it to work, you got to work at it. The people have to own it to make it work. And that's all I have to say on it.
Well, thank you very much, and certainly, I don't know what your name is, sir, but Emerson, certainly I can appreciate your question. Obviously, I've been listening intently. There's been a lot of conversations over the last number of weeks, but I certainly share your frustration. I share the same frustration with the federal government, and the federal government we see as health ministers across the country as a tremendous opportunity to be engaged, to collaborate with our federal partners in Ottawa. And publicly funded Medicare in this country was built on 50-cent dollars in the late 50s, and the average Canadian was 27 years of age. Today, it's a lot different. We're functioning on about 19 cents on every dollar. It's a transfer payment. The federal government a year ago decided that they were no longer going to have any dialogue and conversations on health care, and so I can appreciate your frustration on that. But at the same time, we recognize that as the minister. I've been touring through communities, and we'll be meeting next week with Health PEI. I've got some suggestions on engagement and some strategies. So I think that these discussions have given me some tremendous insight into the concerns. Healthcare is different today than it was 20, 25 years ago. There were surgeries being performed in the western part of the province and babies being delivered. Technology has evolved. There's governments before us that had to close emergency rooms, and we had to close emergency rooms. So it's constantly evolving. But I certainly hope moving forward, I think the success of healthcare and public funded Medicare in this country depends on a much stronger partnership with the federal government, and I look forward to that. Thank you.
Sorry, Minister Curry, I didn't mean to walk away from the mic because there's a lot of people have to talk. I'm not saying it's wrong, but I think if you wanted the communities and the people behind it, We've got to keep them involved. You can't appoint boards. You have to control it, and when the people get involved in it and it's theirs, they will make it work.
Hi there. My name's Marco La Peña. I'm a resident here at Summerside. I actually shared the gentleman's concern over there. When it comes to government, honestly, there's a lot of things it doesn't do right, and I wouldn't put it in charge of something as critical as healthcare. I think the more government gets involved, the more mess you're bound to run into. And, I mean, let's just take a look at it. So what you're doing with the acute care beds, to me, what it looks like is you're rationing out healthcare to the people. Because when you monopolize anything, like you take a look at another monopoly you set up here, Maritime Electric, costs go up, and that's what happened. You're shaking your head, it's not a monopoly. It's, I think with the Energy Act, it is. It's restricting competition, which acts as a monopoly. But anyway, going back to healthcare, so I just took some numbers here. So you were talking about the waiting list. So I went over to the Fraser Institute, which I know some people like to call it a right-wing tank and dismiss everything they say. But, well, I was looking at the provincial health site here, and there's not a lot of information on wait times. And these are one of the few people that are actually willing to do the work to put into it. So I went back to 1999 there, and what they were saying was that the waiting times from a GP referral over to a specialist and then treatment was 18.8 weeks. Last year, 2012, that had increased to 29.3 weeks, which was an increase of 55%. So there we go, we're rationing out healthcare. Basically, somebody needs help. We're saying to them, hey, tough luck. Get to the back of the line, wait your turn. If you gotta suffer, that's too bad. And what happened? So I heard you say repeatedly, basically saying how much money you're pouring into healthcare. And I mean, that's a good thing because the wait times are long. Unfortunately, I look at it, and from 1999, so the same period, health spending was $282 million plus social services. At the last statements, it was $559 million, so that's an increase of 98%. So, I mean, looking at these numbers, it's very clear that going forward, this is not a sustainable program. Medicare is going to crash, and it's going to crash big time. So we got increases of 98% in spending, and the shortages are only getting worse. And we haven't even hit the worst of it yet. We haven't even hit the biggest bulge in the aging population. So as 2008, there were seniors aged plus 65 consumed 44% of all the provincial budget for healthcare, and they only represented 13.7% of the population. Now, as people get older, they're going to require more healthcare. So just to keep up the same level of care now, by roughly 2027, the health budget here is going to be 50%. So, I mean, what are the solutions here? I mean, looking at these, I mean, these are only minor changes, and people are already complaining a lot. And it's only going to get worse. I mean, you can try and increase tax rates, but you're driving people out of the province, so you're making the problem only worse by doing that. And, you know, the government here is already like, what, 2.6 million debt, 2 billion net debt? I mean, where's the money going to come from? How is this going to get solved? I mean, how are you going to, I mean, these are only minor changes. This isn't going to do nothing long term. I mean, is there any, I mean, what's the solution long term? Tax increases, cuts, I mean.
Yeah, well, I won't speak from a healthcare financing point of view, but you're exactly right. People will only stand for such a level of taxation, and there's only so much money can be put into healthcare services because people want, you know, roads, they want social services, they want the justice system to be working properly, education, all those kind of things. Right now, we're around 43% for healthcare, and you know, education is 25% or so. Social services another 15. So about 70% are on 3 government departments alone. The other 6 departments share the remaining 30%. So it's obviously being squeezed. But anyway, I don't know enough. I guess I'm sure the Minister of Finance knows a lot more about finance than I do. But in terms of the clinical changes, certainly your stats from 1999 until now around, you know, the number of procedures, the wait time to see specialists. medicine has changed a lot, and in the last 25 years that I've been involved here in Prince Edward Island, it's changed at least 3 major switches. Family medicine used to be really episodic care. People would call their family doctor, go in and see them. There was a 5 or 10 minute appointment. Nowadays, people that are going in, they have a number of chronic diseases. They have angina that they've been living with for years. Congestive heart failure used to be a death sentence back in the late 80s, early 90s. People now survive for many years with congestive heart failure. So people are coming in with angina, congestive heart failure. They're also diabetic, and they're not sleeping well. There's a number of problems. These appointments are no longer 5 or 10 minute appointments. So there's a much longer, much harder caseload that they're dealing with outside of hospital, because these people used to also be admitted to the hospital at one time. When it comes to specialist care, we have a large problem in Prince Edward Island with the specialists that are carrying on chronic patients in terms of patients that they would see on a regular basis rather than see them in consult and send them back to family medicine. So they're actually doing chronic disease management in their offices, which means they don't have as much time free for new patients to come in for consultations. So medicine is vastly changing, as you say. The role of hospitals are changing. The role of primary care clinics are changing. The role of home care is changing. Everything.
Okay, so again, you're basically saying that costs are going up, right? That basically people require more care, more specialists. So again, costs are going up, so how are you going to, like, other than really privatizing a lot of this, I mean, obviously you can't afford to give all this care. I mean, it's going to go bust in about 15, 20 years, and the waiting lists are only getting longer. And we already have some people that are dying on these waiting lists, a lot more people that are forced to suffer longer and longer. So,
well, but again,
changing a few beds, I mean, like, what's that going to do?
Administration, you obviously have to look at your services, try and be as efficient as possible, make sure people are working the scopes of practice, make sure that you don't keep people in the hospital longer than they have to be, that you decrease the length of stay through new technology, new medications that are out there. There isn't an answer to your question. I mean, I agree. Healthcare has been growing roughly 7 to 8% a year in Prince Edward Island for the last 10 years. It is certainly not sustainable. There will be nothing left but health in around 2025 at the current rate we're going.
So, okay, I'm glad you acknowledge that. Thank you. So is there any idea from the only solution I see is to pretty much destroy the Canada Health Act and let the private sector jump in this and more doctors coming in. Is there any such thinking for privatization?
We at Health PEI are committed to the publicly financed health care.
And that's fine, but you know, nobody here is giving you any solutions to keep that alive. So you can clap and keep living the dream, but it's not going to hold. But thank you for your time.
No problem.
Good evening. My name is Derek Key. I live in Summerside, although contrary to the Madam Chair's instructions, I would suggest that rather than restricting yourselves to those who live here to ask questions, I think anybody who receives service at the Prince County Hospital has an equal opportunity to come forward and ask whatever questions they may wish. I want to talk about utilization, and perhaps that's Health PEI, I'm not sure. Richard sent me a chart so I could keep this straight, but I think it's Health PEI as opposed to the Department of Health. My understanding is that a large part of the decisions that are being made now are based upon utilization within particular areas of the hospital. Is that correct? Oh, Richard. Okay, Richard.
Depends on what you mean by utilization. Are you talking about bed utilization or lab test utilization, or what sort of
How about
utilization?
surgery?
Surgery utilization. So what's the question on that one?
Are a large part of the decisions being based upon, as the Hay report did, and Corpus Sanchez did, and then ultimately is picked up by the Hay report, was based on comparisons of utilization. Is that still the method that Health PEI is using to determine where services will be expanded, where recruitment happens, where things get shut down?
we always look at the utilization of our operating rooms to make sure that we have the most efficient services in the right place. So depending on operations that occur, there are sort of what we'll call everyday common operations, gallbladder removals, appendix, maybe a bowel surgery, that kind of thing. Those are bread and butter general surgery things that'll be done in places that have general surgery. But if you need orthopedic surgery, you can't sustain one single orthopedic surgeon in Summerside, so it's now consolidated into the Charlottetown area where there are 5 orthopedic surgeons.
Okay, agreed. And so utilization, in fact, is the primary factor in making those kinds of determinations. Not the sole factor, but the primary factor.
Yep.
And I understood the minister to say in, I think, Alberton, that as much as 32% of the surgeries that are done currently at Prince County Hospital are done for those outside the Prince County catchment area. Is that correct?
That's correct, outside of the traditional area. So essentially east of Hunter River, about 32%.
So east. So my understanding is that with the expansion at the Queen Elizabeth Hospital, there's now a 5th surgical suite.
No.
No?
There has been requests in the past from the Queen Elizabeth Hospital to open a 5th surgical suite. There are 2 in Summerside, 4 in Charlottetown. On Fridays, a while ago, prior to vascular surgery, there was a 5th operating room run on Fridays to handle some of the load. When the vascular surgeon left, the 5th day disappeared. But there is, and so that's been for the last, I was going to say, year and a half or so since that happened. But there is now pressure to open up the Friday-only 5th OR still because of the backlogs that are occurring.
So it will be fully equipped and ready to go, but it's only going to operate on Fridays.
It's already fully equipped. The Queen Elizabeth Hospital has a number of ORs that aren't being used or being used for different things like, let's say, eye surgery a few days of the week. So some of these operating rooms are equipped with certain types of equipment. They're not all general surgery rooms. So it is fully equipped, has been fully equipped for years. It's not fully staffed. It's only staffed on Fridays, but it's not staffed at all currently.
So when that goes from Friday to Thursday and Wednesday and so on, and the utilization at the Prince County Hospital reduces accordingly, given that 32% come from that particular geographic area anyway, what happens to surgery at the Prince County Hospital?
So you're saying if the 5th operating room opens at the Queen Elizabeth Hospital full-time during the week, what'll happen? Then one assumes that as the wait list decrease in Charlottetown, that people will have an easier access to the Charlottetown surgeons. They may well choose to have their surgery there.
And so my question again is, what does that mean for surgery at the Prince County Hospital? So
there would be less surgery on people outside of the traditional Prince County Hospital area done at Prince County Hospital.
So the Prince County Hospital utilization numbers will decrease accordingly.
The surgeons will tend to fill the operating room time. They have waiting lists as well, so they will continue to operate. Once the surgery list goes down below 0 and there's no waiting list, then you're correct, that will probably happen, but I don't foresee that happening in the near future.
And I guess near future and what we're planning on and working on and so on is where I get lost in this discussion. I guess my request and the reason why I've attended all of these meetings and haven't yet asked a question, because it really wasn't appropriate given that I live in Summerside, I live in Stanley Bridge. That's right. I see some of my Stanley Bridge friends here. It's great. The Minister, are you in a position to make a commitment as to ensuring that the services currently available at the Prince County Hospital continue to be available at least during the remainder of this term of the government?
Absolutely. There's no question. And I made that statement clear. I see the role of the Prince County Hospital, and I see the future direction of this facility to even expand on our ability to provide what we're currently providing. And you raised a question regarding surgeries. The issue on elective wait times, and I'll just pick ortho, for example. The reality of it is that, and the CIHI data is showing that we're at the back end of the country in respect to our wait times for hips and knees. Not happy. We've performed, even with that performance currently, we've hired an additional ortho, and we've also increased the volume of procedures that we've done, and we're still performing at the back end. But as I said, I think this is the third or fourth time. We're extremely committed to services, surgical services here in the province of Prince Edward Island, particularly in Summerside. And I continue to reiterate the role and the value of the Prince County Hospital in that service from tip to tip. And with the increase on the demand and the population, the first baby boomer arrived in 1945, the last one arrived in 1965. We've got a population base right now cruising through our healthcare system between the ages of 50 and 70, and we know the high-cost drivers are in acute care, surgical services. We know that the high-cost drivers are in the last 2 to 3 years of seniors' lives. We are going to have lots of work available for the current facilities. As far as what happens beyond my mandate as the health minister in respect to I can't predict who's going to be in government in 3-4 years' time. That's completely out of my control. All I can do is continue to do the work I'm doing, but we're certainly very, very committed. And I believe in our government, in our caucus, I've got 9 MLAs, right from Bertram to Sheraton to Webster to Sherry to Greenan to Bigger to Gallant, to Henderson, to Murphy, that are advocating every day to maintain services in the Prince County Hospital. So, thanks.
Thank you, Minister. We've represented to you. I went back through to when you first became minister, and I think our first representation to you was earlier in mid-2007. We've met with you 28 times, and that's the clearest I have ever heard it said, and I will sleep well tonight.
Hi, my name is Paulette Halupa, and I was very touched by your story, Minister. Unfortunately, I have a story as well, and it pertains to my father-in-law. He was transferred from Alberton up here to Summerside and was awaiting surgery in Halifax and was left up here for 5 days because no one could decide which ambulance service should take him to Halifax. And we couldn't get any answers. We talked to the person that was responsible at the Summerside Hospital. He tried his best, but we still never received any answers. And the doctor that signed his death certificate at the hospital said, had he been at that hospital 2 or 3 days earlier, the outcome might have been significantly different. And as for wait times, I have grandchildren and that haven't had the best of health, and he was referred to the hospital from Harborside Clinic and still waited 4 hours. This was an infant, a year old, 4 hours. He couldn't breathe, and he waited 4 hours. I'm afraid that my belief is that the dollar is much more important than the people. And I believe that the whole process that's going on here is about which way can we save the most dollars so we can spend them in a way that we think is more important, not necessarily what's more important for the people of PEI. Thank you.
I'm not sure, actually, if you want to get into the details, we can talk later, but there is only one ambulance service on Prince Edward Island, so I'm not quite sure what happened there, but I wouldn't mind hearing a bit more detail from you afterwards. Yeah. Any other questions? No?
Who else has a question?
One of the comments that the gentleman before was talking about what are some of the solutions. I really know that part of the solution is what are we doing around prevention and promotion. Unless we actually do something to improve the health of Islanders in a prevention way, the services that we provide that is sickness-based, chronic disease-based, surgery-based, everything is really, we're pushing up that way. So one of the things that I'd like to highlight tonight and to have people look at is to actually congratulate some of the health promotion and prevention initiatives that are being done in Summerside area through the Public Health Department, through the primary health care networks, and through your primary care people, and don't forget the voluntary agencies and all they are doing through like Heart and Stroke Foundation, the Cancer Society, and so on and so forth. So unless we continue to do more on prevention, our sustainability is being challenged.
Hi, I'm Natasha Dunn from Alberton. Hello again. Minister Curry, you've been really pointing out how this is an emotional issue when you go from community to community. And I would just like to say that it's more than an emotional issue. It's a community issue, and how the government is destroying the fabric of our communities. You've been talking to a doctor from Ontario, and I think it's great that you've engaged with this individual from Ontario, but you couldn't engage with the rural people who are being affected by your changes. We would like to see a plan come from the community instead of a plan forced on the community. So just to kind of reflect a little bit on what Gordon was saying earlier too, I'm going to share a bit of a story with you. Over the last few weeks during these presentations and public discussions, government has used several examples of patients, both rural and fictional, to display how its new plan will better utilize the beds in our island healthcare system. So tonight, let's use a fictional patient, maybe an elderly lady, who we will call Mrs. Curry. Since we are in Summerside, let's say that Mrs. Curry is from Summerside, and her friends are in Summerside and all of her family, including her darling son, who is the light of her life. Few of her friends drive anymore, and her husband is deceased. Mrs. Curry has been in Summerside Hospital for an extended stay following a broken hip, and it has become clear that due to her age and physical condition, she will not be able to return home anytime soon. Mrs. Curry is sent to O'Leary for extended care. She knows no one. Her mental health is failing, and her friends find it difficult to make the trip up, but once a month or so, someone will come up on a fine day. Other than that, her only company is her darling son. Unfortunately, he works very hard in Charlottetown every day until 6 p.m., and visiting hours at the O'Leary Community Hospital end daily at 8:30. If he travels up on weekdays, he only gets to visit his mother for half an hour. If Mr. Curry makes 4 trips a week up to visit his mother during her 6-month stay, and let's just count the drive from Summerside to O'Leary, how many kilometers will he travel in 6 months just to visit his mother? Any idea? Yes, I do have the answer, Paula. The answer is 12,688 kilometers. If his car is fairly easy on gas, and let's say he burns $20 worth on every trip, how much money will Mr. Curry spend on visiting his mother, traveling from Summerside to O'Leary for 6 months? $2,080 just in gas. And just one more question. Who will pay for Mrs. Curry's transfer to O'Leary? Because if you can answer that, because no one seems to know the answer to this question. Thank you.
Thank you very much, Natasha. Certainly, just in respect to the whole discussion around facilities in the province, and I was the minister back in 2007, 2008, that was part of the government. I think it was probably closer to getting elected. There was a debate on the table, particularly in the western part of the province, about the single hospital versus all of the community hospitals. And certainly as the minister, after looking at the issue and looking at the reports, certainly as the minister, I was a very, very strong proponent of maintaining levels of healthcare services in communities, in whether it's in Tyne Valley, whether it's in O'Leary, whether it's in Alberton or Tignish. So I basically did not support the one big super hospital in Bloomfield and turn everything else into other facilities, just to be clear. In respect to the province of Prince Edward Island, we're very fortunate. We're fortunate that we have 5 community facilities. We've got 2 acute facilities. We've got an Edda-province budget that is exceeding $50 million. And our priority is to make sure that we have good quality services at the appropriate time by the appropriate provider in the appropriate situation. And the gentleman by the name of Marco raised an interesting point about sort of the evolution and the pressures and budget growth and so on. Well, our investments in the last 5 years haven't solely been in acute care, because we recognize we have to pay attention to acute care, not only here in the province, but we have to respect that there is islanders from tip to tip in this province that do need to be airlifted to the IWK, do need to be transported to Moncton. We're seeing 6 ground ambulances a day at 9 hours per day being transported because of our population is getting older, and we have an unhealthy population base. And the Chief Public Health Officer's report indicates that to us. Those are just harsh realities. So yes, at times there is transfers that do occur from facility to facility. When a transfer is deemed if an individual is transported to a facility to free up a bed for a more sick islander, the system pays for that transfer.
J'aurais 2 points à apporter. Mon nom est Théodore Thériault. Je demeure à Avram Village. Le premier point, c'est concernant les soins de longue durée pour les personnes âgées. La communauté francophone a fait une demande pour obtenir 11 licences ou une licence, en tout cas pour une dizaine de lits de soins de longue santé pour offrir les services en français aux francophones. Et cette demande-là a été refusée. Elle a été refusée et a été donnée à une entreprise qui n'a aucun engagement à offrir des soins de service en français 24 heures par jour, 7 jours par semaine. Donc, il faudra, je ne m'attends pas à une réponse ce soir, mais il faudra répondre à la question, parce que je pense que la communauté va revenir et va, si on ne peut pas accéder, il faudra aller au premier ministre. Le deuxième point, vous avez parlé de la création d'une dizaine d'emplois pour les mesures d'urgence, pour les services d'ambulance. Combien de ces postes-là vont être désignés bilingues?
Well, thank you very much. I don't speak French, but I can respond to your question in English. I guess in respect to the first question was based around, I believe you were referring to Chez Nous. Chez Nous was the facility in Wellington that was part of the RFP process for the long-term care beds. Currently, there was an RFP process. I believe there was 7 public beds added to the community hospital in O'Leary, but the other 55 beds that were part of the RFP process, which was led and implemented by Health PEI, there was a process, there was criteria in the RFP targeting long-term care beds in the Charlottetown and the Summerside area. That RFP was awarded. I believe 10 of those long-term care beds were awarded to Andrews here in Summerside, and there was another volume of beds that were added to facilities in the Charlottetown area. One of the issues during the evaluation, the criteria, is the volumes of wait times in communities across Prince Edward Island. Obviously, we've got approximately about 149 individuals waiting for long-term care placement in the problem. Obviously, the Charlottetown area, because it's a larger population mass, has a wait time of approximately 60 individuals at any given day waiting for long-term care. In the Summerside area, I believe it's in around 25. In the western part of the province, that number is a little smaller, and in the eastern part of the province is a little smaller. So the RFP process was based on criteria that was independent and separate from government. Our responsibility is to commit to the 60-plus beds. I do know that the new $18 million facility that we have opened up here in Summerside, there's a wing, an element of that provides French language services, and certainly I know in the Legislative Assembly the French Language Services Act has been proclaimed, been implemented. So certainly as government, we recognize the language from a service perspective. So I know that Chez Nous, I know the MLA in the area, Sonny Glant, lobbied and worked very hard. but I was not directly involved with the RFP. That was based on sort of criteria, based on demand and pressures that were in the long-term care. But certainly am pleased that the new facility here does provide French language services. I believe they have a French wing here in the new manor here in Summerside.
Merci, Monsieur le ministre, mais je pense qu'il ne suffit pas d'avoir un corridor pour mettre les personnes francophones pour qu'ils se sentent à l'aise et soient capables de vieillir avec une qualité de vie. La région évangéline prend soin de ses aînés avec une programmation communautaire, avec des bénévoles qui s'occupent d'eux et qui les accompagnent, et avec les gens de la famille qui les supportent à une distance de moins de 10 km. Je sais par exemple qu'il y a plusieurs aînés francophones qui sont placés dans des foyers ici à Summerside parce qu'il n'y a pas assez de lits à Évangéline. Donc, je pense qu'à un moment donné, ce qu'il faut comprendre, c'est que la qualité du soin, si elle ne coûte rien au gouvernement, elle devrait être autorisée. Et la deuxième question que je ramène sur le tapis, c'est les postes qui vont être créés comme ambulanciers. Est-ce qu'il va y en avoir de désignés bilingues?
Well, thank you, and you do raise a good point. Obviously, just another example of our populations and communities getting older. I know Chez Nous is a community care facility which provide levels 1, 2, and 3 before seniors are identified as long-term care level 4s and 5s. So certainly, I knew that Chez Nous, I met with Chez Nous with the MLA. They did a fantastic presentation. Certainly, at this point in time, obviously the RFP process went out. I would certainly encourage Chez Nous and the community to continue to advocate for long-term care beds into the future, particularly in the community, particularly at Chez Nous. And I'm sure that government will continue to look at ways that we can address some of those needs. So certainly at this point in time, as part of our focus, we replaced the 5 public manors here in the province at a cost of $70 million. But our commitment to additional long-term care beds is solely targeted at the private sector. For example, Andrews and Summerside, Gillis Lodge, a number of facilities across the province. So Chez Nous, in the future, will certainly have opportunities to continue to be part of a process. And certainly, I know that Health PEI does recognize the needs in the community. So I would certainly encourage the community to continue to advocate and to lobby government, which is part of the role for those beds moving forward. So I'll let Matt take the next question.
Bonjour, monsieur. Merci pour la question. I'll just start out by saying that thank you very much for the question. We do currently offer on all of our ambulances a fully bilingual service. We are presently trying to hire more and more bilingual staff. At a initial stage, approximately 2 years ago, we didn't have a fully equipped staff, especially with different cares of paramedic, advanced care. So we really put a recruiting drive. We now have a full complement of staff amongst all of our skill levels, and we're now focusing on improving our language. We have a service that's equipped on every ambulance that can provide a fully bilingual service, not just en français, but in any different language. We have a language line through our communication center, which you can then speak to and communicate with our paramedics in your preference of language. But as I said, we are improving our ability to serve people in the French language within Prince Edward Island. Thank you.
Good evening. I really appreciate your comments, Donna Murnahan, around preventative health care, health promotion. As a mother of young children in the Summerside area, what kind of initiatives is the government looking at for health promotion of our young people? Because they are our future recipients of care. What are we doing around obesity, breastfeeding rates, healthy eating, activity? What's the future plans for that?
A great question. Certainly, at our department, Health and Wellness, we do have some initiatives moving forward. Obviously, we do have, we're currently finalizing a provincial wellness strategy that we will be presenting publicly in the future. Certainly, as the minister, the other half of the health responsibility is the wellness side. And certainly, we're continuing to find ways, and I think we've made some positive steps forward in respect to initiatives in wellness. I know that programs like the Go PEI initiative has really become very popular in communities across the province. We have a number of other initiatives in respect to healthy eating programs. We certainly currently are very, very engaged with the Healthy Eating Alliance, working with schools across the province. But we just recently have partnered with the federal government on the bilateral sport agreement. We have implemented what's called the Active Start program, which is focused on 3 to 6-year-olds in our kindergarten and EYC programs across the province. And that's a play-based program to introduce and teach kids the fundamentals of play and introduce the importance of active starts as children. Obviously, I recognize as a father of 2 children, things are a little different today than they were 25 years ago. Technology has become a huge distraction. The days of parents going out to the front steps calling their children in from team chase and street hockey when the street lights come on are long over and gone. And I think we as communities and municipalities and provinces have to recognize that we have to find continued ways to engage the discussion around wellness and activity. We certainly are, I know with our 3 regions, our rec programs, we're looking and currently doing after-school programming, which is free programming for children. We're looking at using schools on the weekends to utilize the facilities to get kids moving and become very active. Sport, in some areas, some particular areas, has become very expensive, and I certainly, as the minister, recognize that, depending on the sport. But there's a high volume of sport and activities that are very cost-effective. So we're going to continue to embrace the conversation. We recognize from the Chief Public Health Officer's report that there's some serious concerns with the overall health and population of our province. So these initiatives moving forward will hopefully change the culture and change the culture of wellness here in the province. So, thanks.
I appreciate that. I really hope that that continues to look at as well what our health system can provide for these individuals. So what kinds of teaching can we do with parents in clinics, in these primary care clinics, around healthy eating, and what are we doing when we find an obese child, and how do we help those parents? Luckily, I get to call my kids in at night because they enjoy playing outside. I appreciate it. Thank you.
I'll just add to that as well that each of the primary care networks have nutrition counselors. They do have other staff that are available for that. The Harborside Clinic has started a pilot program on obesity management for patients in the East Prince area that's operated out of both Harborside and the Kensington Clinic. So there are a number of initiatives there to try and do that. Just for the audience's knowledge as well, there is a symposium tomorrow night at the Queen Elizabeth Hospital on initiatives to try and improve the breastfeeding rates on PEI. So if anybody is in the Charlottetown area tomorrow night, they should go. I think it's around 7 o'clock at the QEH. Yep.
Hi, my name's Mike Rubin, and I'm from Charlottetown. I'm with the NDP party of Prince Edward Island, and I have had a chance to use Prince County Hospital for a day surgery with one of my boys, and it was a fantastic experience, so kudos for that, obviously. Great to see that you have a strategic plan. I was very excited to see that tonight. Strategic plans are only as good as a dollar figure attached to them, obviously, right? So that's a reality of movement forward. So Marco's not far removed when he says we have a healthcare system that is going to be really stretched to the max in terms of dollars. I am interested, Donna, if you could elaborate a little bit on mental health and addiction services, because probably the biggest challenge we have as a province is youth addictions, whether it be gambling, alcohol. These are real stresses on the healthcare system. So when you talked about, and first of all, that you acknowledge that we're not doing a good enough job, kudos for you, because honesty is the first step to resolving the issues, admitting we have one. So I want to know if you could elaborate a little bit tonight on how you see that playing out.
or Doug.
I'll just, Mike, a good question. Obviously, in the acute system, mental health and addiction sometimes sort of gets moved to the side, and certainly as a former educator, very interested in the whole conversation and implementation of policy and reviewing current policy on addictions and mental health. And I'll use, last week we brought in legislative changes to really clamp down and control the volume and level of opioid painkiller prescriptions here in the province. We've seen a substantial increase in the volumes, I think 17.8% over a 5-year period. So as Minister, that's a concern. I've met with frontline staff. Our provincial detox facility, which traditionally over the years has been a detox center for individuals struggling with alcohol addiction. So now we're looking at almost a complete shift. 60% of the individuals coming in are individuals struggling with opioid painkiller addictions. So it is a problem. I brought that legislation in. We did do a very extensive, engaged review of mental health and addiction services here in the province. There was an intense response, which sends a very powerful message for me as the minister, that it's an issue that probably has impacted lives of everyone here in this room. And it's an issue that I want to, when I bring the report forward, we'll have recommendations and respond to the report. But I think the success of that journey will be the continued engagement of the issues around access to mental health and addiction services here in the province. I recognize as minister, our main acute referral mental hospital is aged, it's old. Certainly we had a great discussion in the Legislative Assembly around the future of services. There was a decision back in the late 90s by the government of the day where they downsized the number of detox beds in the province. At that time, there was probably some policy and fundamental reasons for that. But I think we need to step back in the whole conversation around mental health and addictions and get into a really, not only respond to the report, but look at ways that we can continue to engage the conversation in communities across Prince Edward Island.
Sure, if you don't mind.
Thanks, Mike, for that question. One of the things that I'd like to share probably is some of the initiatives that are partnerships through the Comprehensive School Health Group. And the Comprehensive School Health team is actually educators, health people, researchers, mental health and addictions groups coming together to really look at what are we doing with our young people around mental health and addictions. And the area we are focusing on is what we call mental fitness. And it's about developing positive self-esteem in children, because we know there seems to be a really strong link between how children feel about themselves in terms of their self-esteem and then the choices that they make in terms of starting with tobacco usually. I call it the gatekeeper to the drug operations. So how can we work in concert with all groups, whether it's community, it's education, it's health, it's researchers, it's mental health as well. Now, in addition to that, we actually are looking at positive mental health toolkits that we can start developing, because it's one thing to say children's self-esteem is low and what are we going to improve it, but having the resources and the tools to work with schools, to work with community groups to help do that is the process that we're working on. And surprisingly, there is not a lot out there to help parents, to help schools, and that's one initiative. So just wanted to share that with you. The other part of that has to do with, as I teach at the University School of Nursing, and I'm very proud to have be able to report to you that actually the School of Nursing has adopted a school health curriculum as a part of our curriculum for nurses. So that will feed into the system as well as we have our nursing students throughout the system in schools, in public health departments and so forth, doing work on behalf of youth health.
Just maybe another question, maybe a point. So the young lady was talking about it, I mean, not necessarily to you, Donna, so I'll let you sit down, thanks. When the young lady was talking about her family, when we talk about the statistics around child poverty in this province, and so that means that kids are not eating well, right? That's obviously a determinant to health. So these are huge challenges for not only for Prince County or Queens County or wherever, how are we addressing these issues? And if you want to know, ultimately we want Dr. Wedge not to have people in the hospital, right, to live a healthy life. So that starts at 1 year old, right away, and how do we change the system? So my point to that, and it's to Doug, and we had a chance to sit at the table together at UPEI, is we have assets as well. Assets that we currently have are a full track at UPEI, our gym. So our post-secondary institutions are assets as well. And what has to happen, and I say that as my own expense because I was there as well, they have to understand that, first of all, they're a public institution. And as a public institution, they're open to the public first. All right? So we fund them as taxpayers. So the pools and the rinks and the gyms need to be accessible. And most importantly, my last point, is accessible to those who have not the means to use them. Right? When you make that commitment, then you make commitments to healthy lifestyles. So thank you very much.
Hi, Rod McNeil, Tyne Valley. Just a quick question that I promised someone that I would ask tonight, because when I came in, someone just slipped me a question. I guess they're shy to be at a mic. And I think you answered the question, but I said I would ask it for these people, and it was from staff at Prince County Hospital. And they wanted to be assured, because they hear strong rumors that there very well may be some serious cuts coming either to staff or services in this fiscal budget. And I honestly don't know of anything on that, but I promised some people that I would ask that question, so I am. Yes.
Well, thanks, Rod. And I think I've already answered that question in respect to a couple times. I mean, and I'll reiterate it again. Our commitment is to support Prince County Hospital to be not only a town facility, but a regional facility, and a key part of an integrated system here in the province of Prince Edward Island. And as I alluded to, I shared, I don't know if you were here, there's a number of, there's 2 clinical initiatives right now that are in front of us that we're embracing, and there's a 3rd educational commitment. So we have made investments in Prince County Hospital, and we're going to continue to make investments and continue to commit to services here at the Prince County Hospital.
Yeah, thank you. Just whether one, I would just have a quick comment and a little bit of a question about this whole exercise. I mean, yes, you're right. It's been a journey the last 3 weeks. Some of us here have attended most of these meetings, if not all of them. And there are, I think that the objectives and goals that your department is trying to do, we probably all agree with in the basis. I think we respectfully disagree with some of the methods that you're using to do it, and I'll leave it at that. I'm not going to elaborate on that in terms of our own particular things that are happening in our little hospital in Tyne Valley. But what I would hold you to is that in the last week or so, there has been some statements made about how effectively these things will improve the waiting times for surgeries. Up to, they're saying 50% reduced wait times. I don't see that happening anywhere to that level. Certainly not in the immediate future with these things that are happening. But I'd like you just to speak a little as minister to that particular statement that was made, that the wait times will be reduced 50% because of these particular initiatives.
Well, you raise a good point. Obviously, I'm not sure on the number of the 50%. That certainly didn't come from myself. I have not heard that number, but this has been a very interesting journey. Obviously, going out to the communities to respond to not only the investment, but the change and sort of just the dialogue back and forth. Obviously, I'm committed to, and I'll make this as a public statement, and I'll make a public statement next week, that I'll be back into the communities in the fall, updating communities on the investments that we have made and the changes that we have seen, hopefully. I've got some ideas in respect to what I've witnessed and what I've experienced over the last number of weeks in respect to public engagement, in respect to ways that we can continue conversation with communities across Prince Edward Island. I will be having a meeting next week, a debrief. I have some thoughts around where we go moving forward in respect to the whole conversation about healthcare. And it looks from my experience in the communities I've been in, there's community leaders that are engaged or interested in healthcare. So I'm going to capitalize on that opportunity, and you have not seen the last of me, and I'll be back into the community, and hopefully in an environment where it's more engaging, looking at more solution-based discussions as opposed to sort of steering the ship in the direction that we have been steering it over the last little while.
Yes, thank you, and I'm sure we'll see more of you as well. Thank you very much.
And I see two people here ready with questions, so I'm going to suggest that after this gentleman is finished that we'll be done with the questions for the evening. So please go ahead.
Yeah, and the problem is I'm going to be a little long too. My name is Margaret McKay, and since 2007 I've had quite a journey through the healthcare system, which has not been any fault of my own, but it was a work situation that caused the problem. And I'm very much a believer in preventive healthcare, and I practice it heavily. But there's been a number of issues that I've run across in the process, and one has been the last trip I had about 2-3 weeks ago to Prince County Hospital to emergency. They seem to have changed the way they handle people when they come in an emergency, and it seems to be down to yes-no answers. Well, my case doesn't fall into yes-no. It seems to be that they're trying to speed up the process, get you in and out as fast as possible, and they don't even bring up your file to find out what's wrong with you. That gives me a great deal of concern, because the way you people are talking right now, it sounds like there's going to be a whole lot more cases hitting your emergency department here in Prince County Hospital than there has been. And as it is, some of the waits are sometimes quite long. And it really annoys me when somebody goes in, and I've seen this happen, and I've been told by people from Prince County Hospital and other places, what's happening is people are going into Queen Elizabeth Hospital, registering at emergency in Queen Elizabeth Hospital, and then driving to Summerside and walking in ahead of us. I got more questions.
Yeah, no, that's no problem. Obviously, I don't know the specifics of an individual case, but certainly if you think the care hasn't been appropriate, you should really contact the hospital, the medical director at the hospital, or the staff that are involved with patient both compliments and complaints should probably sit down with you and go over some of that stuff. I don't know what to tell you in terms of people coming from Charlottetown and getting in ahead of people in the waiting room. The Prince County Hospital works on a triage system, so they see the triage nurse and they're assessed at whatever level of triage, if they're level 1, 2, 3, 4, 5 kind of thing. So if somebody's there for, let's say, a prescription refill on a level 5 and somebody's in with abdominal pain, they are going to come in first. Does that make any sense? Or? Yeah. It depends on the individual situation. But okay, carry on.
Finish what you're going to say.
I was just saying that I thought you had another question, sorry.
Yeah, I have a lot of questions. I understand your administrative costs are 3 times higher. Now, I read this somewhere, and it might not be true, but 3 times higher than the other provinces on the healthcare system. That really concerns me, especially when you get on elected boards.
Yeah, well, there's different ways to measure administrative costs, and we could probably talk about that for an hour, but essentially with Health PEI, we follow the Canadian hospital reporting system that's done by different regional health authorities across the country. And when you follow that system that uses standardized definition as to what is administration, Health PEI's administration is in line with the rest of Atlantic Canada. And it's about 4.5% of the total healthcare budget. But if you look at it in terms of everybody who works in the finance section, everybody who works in corporate services, the board, the senior management team, the nurse managers, including the ward clerks on the ward, those are all considered administration because they're not actually frontline clinicians. That raises the numbers considerably. And because of the way Health PEI is set up, we actually have a lot more of those services in the Health Authority than we do in the Department of Health. So if you look at it all combined, it does appear to be a lot larger. But if we had a lot of those people in the Department of Health and we just went with Health PEI, it would be a lot smaller. There is actually an explanation that's a bit longer on the website that'll explain it to you a bit better.
That to me sounds like top-loading it with management, and I often found that if you cut out some of the management, you can get to the decisions a whole lot faster. But that's my opinion on it. One of the in my process of being referred to Halifax, I found that they want, in order to cut costs for the hospital care service here in Prince Edward Island, and Halifax is expensive and the costs are much more. What they were doing was getting the tests done here in the island to send to Halifax. Sometimes those aren't completely reliable because the quality of the equipment they have in Halifax is way beyond what you fellows have here. And in one case, they only turned on the CAT scan about once a week at that time in the hospital. And that meant longer waits in Summerside area. I'd sooner even driven to Charlottetown to get the CAT scan done in Charlottetown if it would have speeded up the process, because you can only be sick so long and off work so long, and it adds the cost of people being in income and everything, especially when you're trying to charge us more taxes too.
Well, I would respectfully disagree with the quality of the CT scanning equipment we have here in Prince Edward Island. It is state-of-the-art. It has been provided by the foundation.
I'm not talking the quality of the CAT scans. I'm talking the quality of something else. It was breathing tests that were not near the quality that they were in Halifax. But that's another thing. I'm not going there.
Well, we do have, certainly our respiratory department does have top-notch equipment as well, but we'd have to look at the equipment.
My concern is if they're taking a long time to do the tests, it takes longer to get people referred. It affects the people in incomes because you can't go back to work till you find out what your problem is and get it corrected. Then it may save the PEI healthcare system money, but it's not saving the person that's sick time and money either. And the thing is, when you're working, you pay income tax. When you're not working, you don't pay income tax, which doesn't add to Mr. Sheraton's health dollars or income in his treasury. So the quicker that you can get somebody to Halifax and referred, the faster they get well. And so
Health PEI doesn't.
If it could speed up those cases where they're being referred, it would do a whole lot to improve it for both the people that's seriously ill and your treasury.
So Health PEI does not restrict patients to having the test done on Prince Edward Island if they're being referred by a Halifax physician. If the Halifax physician prefers to have the test done there, Health PEI still pays for the test. When it comes to testing, there isn't a big difference in pay to have the test done from one province to the other. The biggest difference is the admission to the hospital at the QE2 compared to admission to a hospital at somewhere like Prince County Hospital. There is a difference there. Certainly if you're in ICU, there's a big difference as well. But to see the physician, to have the test done, there's not a big difference.
I'm wondering who's going to pay for the transportation for people that maybe after the surgery transported to O'Leary, and when they get well and they come home, or if they're in Surrey after their operation and they're going to this extended care, because of the fact that you can't keep them in Prince County Hospital or the QE, who's going to pay for the transportation home? Yeah. Because, as Ms. Dunn said, the dollars just in visit and the family members are going to be extensive.
So I just want to reassure everybody that not everybody who has surgery or has a stroke and is in Prince County Hospital is going to be transferred to another hospital. The vast majority are going to be treated at Prince County for their normal length of stay and sent home. It's the ones who require extended care that will be transferred, and that's a much smaller number. And as the Minister pointed out to one of the questions earlier, if the transfer is being done at the request of the system to utilize beds better, the system pays, not the patient.
Well, the thing is, too, if you can free up some of those beds, also it may mean that people may not have to be transferred.
That's right, yeah.
One of the things that really bugs me is your ambulances that are coming up Granville Street at 10 kilometers over the speed limit. And what we're getting is you can hear them coming for half an hour almost, or 15 minutes before they get there. The other thing is the cars, instead of pulling over and waiting for them to pass, are speeding up and going way ahead of them. So it's self-defeating. And the most important people that you want to have at an accident scene is the ambulance attendants, not the RCMP, who have no speed limit on them.
I'm not sure what to tell you, but
I
whether
think
Matthew
you need
has
to
an
change
answer
your
for that,
legislation.
but certainly there would be an education thing. People are supposed to pull over to the side of the road when the ambulance is coming, but I don't have any experience.
Well, they're not when they're on the streets of Summerside, I can tell you now.
Thank you, ma'am, for the question. Just to give you a little bit of background, I definitely understand your concern, and it's a common one amongst members of the public. The reason it's not a legislative requirement, it's a company policy that we regulate the speeds of our ambulance. On average, on a 25-minute trip, the amount of time saved from an ambulance exceeding the speed limit is around 45 seconds. Although that time is extremely precious, we've done extensive studies around the world, and the rate at which an ambulance could be involved in a collision goes up by about 65%. So the reason that we've limited the speed a little bit is it's very important for ambulances to get there, but to get there safely. When an ambulance is involved in a collision, not only are we delayed getting to that scene, but we're also sending other ambulances to then care for those crews. So we take it very seriously. We analyze our statistics a lot, and we make sure that we try and get there. But especially in those limits where we've limited the speed is in highly populated areas where really the ambulance doesn't have time because of the weight of the vehicle. It's around 5 ton. If a little child or a dog or something came out, they may not have time to stop. So that's why we've restricted their speed limit in those areas.
I'm well aware that you had 2 accidents. I think one was in New Brunswick, one was in Nova Scotia, where there were ambulance drivers. Maybe you should be sending your attendants or your drivers on high-speed driving courses, and maybe you wouldn't have to do that like the police do. Anyway, the other thing I want to bring up is I'm in 2 minds of this situation where you don't have doctors in the smaller hospitals, because I've walked into the hospital where, and it doesn't happen now in Prince County, but it used to happen, where the doctors were sleeping. If you went in at 3 o'clock in the morning, what was happening is they woke up the doctor. The doctor was not with it. Now, the situation is, it's not happening in Prince County anymore because you're getting so many drug problems coming into Prince County. But that really concerns me of where you're going some of this health care, because if you have a small hospital where they might get 1 patient a night or 2, and the doctors usually are allowed to sleep in emergency in those cases, then well, I had one case, and I had to say something to him about, if you look at the file, and I got referred for vertigo instead of the real case. And after, I guess, when he woke up and read the file, then he realized that it was a much more serious problem. And, I mean, to go home at 3 o'clock in the morning, 3:30 in the morning in that situation was not the pleasantest situation. And that's just a comment. You don't have to answer that. The other thing that Nova Scotia does that you fellows are not doing and you can't afford is Nova Scotia has a medical helicopter. And they can go into ambulance or into accident scenes, pick up those patients and take them very quickly into places like the VG in Halifax or Halifax Infirmary or whatever. You folks can't afford that. And it really scares me because if you go up to Tignish, if you want to get back to Summerside in an hour, you have to do some hard, heavy driving to get back to Tignish, from Tignish to Summerside in an hour. And most likely, there's been a couple of really serious accidents up there in the last little while. And most likely what's going to happen is that person is going to be dead before they get to the hospital. And even your attendants, when they get there, there's not a whole lot they necessarily sometimes do. But if you had a helicopter pick them up, it might give them a few more minutes of life and do more to save them. And obviously in PEI, it's not within the budgets.
I'll just point out that Prince Edward Island already has an ambulance bypass policy in place and has for the last couple of years for serious trauma. So we don't actually even stop at the Western Hospital now, and has been for the last few years for serious trauma. So we have bypass policies in place for a few things, including stroke as well.
Is that coming into the hospital, or is that going to the actual accident scene?
No, coming to the hospital, from the accident scene to the hospital.
Because, I mean, a helicopter can be in and out in 15 minutes or less, emergency helicopter.
I guess if
whereas an ambulance or any other vehicle cannot, you know.
Yeah.
So it greatly concerns me that...
So if the helicopter was in Summerside and the crew was at home, it'd be a lot faster than an ambulance. But if the crew was in the helicopter and the helicopter was near the scene, I agree it'd be faster, yeah.
But you're leaving a hospital in Montague, and they have a far smaller population, and I don't want to divide the island one against the other, but you've got a far smaller population in eastern PEI than you do in western PEI and Prince County West. And it seems that Prince County is getting hung out to dry. Especially when you get a larger area, you get a larger population.
The Kings County area has 22,000 people. West Prince has 15,000 if you include the Tyne Valley area. Kings County
Are you including Charlottetown in that area?
No, Kings
Or part of Charlottetown, Stratford?
Kings County and West Prince. Charlottetown's a different.
Thank you.
Kings County has 22,000.
I think you better go back and look at Stats Canada and see what the actual figures are.
We look at them all the time.
Thank you very much for your comments tonight. Thank you. And you, sir, have the last question. Thank you.
Thank you. My name is Don Humphrey. I'm from Surrey. I wasn't going to say anything until the minister's last comment. I've been to almost as many meetings as the minister, starting in Alberton. And when I listened to the radio the following morning, and the minister might be on, and he said, "We're going straight ahead. No diversions, no slowing down. It's going ahead." And what got me to my feet was that the minister said, "Well, I'll see you in the fall, and that's when everything will be done." Now, in all these meetings, this is the only way that we have had a face-to-face consultation with the government, with the minister, with Health PEI, about the changes coming to rural health care. This is the only way we've been able to do it, and some of the meetings have been a lot livelier than in Summerside. We're glad to see the turnout here, too. So, see you in the fall when all the things are done. Then we'll have another chat. But let me say one more thing. Today, Wednesday, the implementation committee met for the first time in Surrey Hospital. Everything's going ahead according to the minister's plan. I don't think this minister believes in consultation one way or the other. So you can see why "see you in the fall" really got me out of my seat.
Yeah, well, thanks, Don. I appreciate that. Don, as I've alluded to, and I think I've been pretty consistent with my message, whether it be at public meetings or whether it be in the media, my priority is healthcare access for all Islanders, whether it's in your community, whether you need to be taken to Charlottetown, whether you need to be taken to Summerside. Our system here in the province of $570 million has to be there for Islanders when they need healthcare. But we also have to be there when a service is required outside the province. There's no hidden secret. There's no agenda here other than we've got some real pressures facing our system. We're seeing long wait times in emergency rooms. That is not quality health care. And as the minister, I know these issues are difficult, and I would be more than willing, if you have a magic bullet or a solution for me as the minister, like I said to Alan McPhee the other night, I'm more than prepared to embrace that solution. But I've yet to hear solutions. The reality of it is we've got pressures on our system. We've got islanders that are getting older. We have to be there for people in communities across Prince Edward Island. Is healthcare going to look differently today than it did 10 years ago? Yes. Is it going to be different in 25 years' time than it is today? I'm not going to be here in this chair and this responsibility when that comes, but it will be different. I'll guarantee you that. I'm just being frankly honest here with Islanders. I'm being straight up. We can't continue to sustain and grow the healthcare budget at 6.5%, 7%. We basically last year spent on an operational increase in spending at 4.1%, the fourth highest operational spend in the country. So we're spending money. This year, Nova Scotia froze their health budgets. New Brunswick brought in a -2 on their healthcare budgets. Our province committed to a 3.1% increase. We're spending money, but we have to continue to evolve the system, and we have to respond, and we're going to continue to do that. I've got a responsibility, whether you live in Surrey, whether you live in Charlottetown, whether you live in Tignish, that we have a level of access and service and to try to do the best job that we can do. In reference to the comment regarding engagement, I basically said that I've heard from Islanders. I've got some suggestions for Health PEI in respect to engagement, and I'll continue to respect that. And I will be looking at ways that we continue to listen to communities and respond to communities. So as far as my responsibility, I've been completely respectful of the concerns and issues. We haven't closed a hospital bed. We haven't shut anything down. We support services in communities all across Prince Edward Island. The Corporate Sanchez report doubled our home care budget from $9 million to $22 million. The investments in primary health care have been strong. We've got more physicians, more nurses, more LPNs, more SUWs than we ever had. We've expanded scope of practice from our nurse practitioners to our pharmacies. We're responding to the demands and the pressures on our system. Thank you.
Thank you, Mr. Minister. As you might appreciate, I've heard your talking points for the last 3 weeks. I've heard you've changed your tone at Montague, and you changed it for the first 90% of this meeting, but now you're back to your talking points. All right. In Surrey, there was a suggestion from Dr. Henbest. And I know, I am the chairman of the foundation, I know firsthand what goes on in Surrey. And you brought up that Surrey had empty beds. Well, Dr. Henbest's question is, why in hell didn't you call Surrey? And, let me talk. Surrey we have this hospital, and it's built. It doesn't cost anything. And why isn't Health PEI filling those beds? We have the hardware installed. We have the software installed. The software is the nurse who answers the phone in Surrey, and the nurse, whoever, picks up the phone and requests a bed from wherever. And you ignore that. You ignore empty beds in Surrey. You've been doing that for years. Surrey has acute care. You cannot define acute care, even though you have offered subacute care, whatever the hell that is. And we do long-term care for people who can't get into our small manor, which you did not increase the size when you built us a big, beautiful manor, and you knew the wave was coming. You did not increase the capacity, even when it was suggested that you increase it or have a possibility of building another pod, another 13 beds. And we already are doing alternative level of care. We do that all in Surrey. And you did not get on the phone, or Dr. Wedge's people, or the hospital. The hospital contingent is not here. Dr. Rosemary Henderson, she was told almost 3 weeks ago, get on the phone, call Surrey, we'll gladly take your overflow. There is my suggestion. Yeah. There's no reason to close acute care in Surrey. There is no reason to close acute care in O'Leary or Tyne Valley. You're not going to save a nickel. You're only going to cause disruption and misery to those people. There is nothing that can be gained by closing these little bits of acute care. Why are you doing it? We don't see why. Thank you. I'll stop.
Thank you very much, Don, and I appreciate your passion. Just in respect to the Manor situation, obviously, here in the province, we've got wait lists. We probably per capita, compared to any other province in Canada, have more long-term care beds than any other province per capita. I'm not a supporter of institutionalizing our seniors, and we're doing that at a fairly substantial rate. We basically have chosen to go down and move our investments into home care to keep our seniors where they want to be in their homes. That's as a result of the double investment that we have made. In respect to the Surrey Hospital, you and I do agree in that. We have to use the facility to its full capacity. Last year, that facility that functioned on 72% occupancy. The 84% of the residents in the Surrey area got all of their acute care needs at the KCMH and the QEH. But I do respect the 16% that were being served there. I mean, I'm just sharing the data and the information that was presented that night at that meeting. We need to fully utilize every asset and to make sure that there's no empty beds, so we can make sure that residents in your community, or whether they're in Summerside or Charlottetown or Albert or Tignish, are not sitting on stretchers, are not going in for surgeries, and there's cancellations, and they've got family to support them there. So thank you very much.
Then why are you eliminating acute care? Why are you eliminating acute care? Nobody cares to answer? This is your last chance before fall. Well, you were pretty well done before you started the meetings in Alberton, because you never answered. You just gave talking points. Overaging population.
Thank you, Don. Thank you. Thank you. Thank you, Minister. Thank you, Dr. Wedge and Donna Murnahan and Matt Crossman. And Minister, you get the last word.
I just want to say, just to conclude, obviously tonight's meeting is about the PCH, and I know that we have gone into some other discussions. I certainly want to acknowledge individuals who are here tonight that took time to come here. I certainly want to acknowledge the community members from Tyne Valley, O'Leary, Alberton, Surrey, Montague. I know that you're very passionate. We'll continue to have conversations on health care moving forward. I certainly have gained a lot of insight over the last number of weeks, and certainly I want to thank you for coming tonight and your conviction and your passion for your communities and the services that are being provided there. So thank you very much.